This is my fourth lecture. Again, a great honor to be here with you and share these 3 days of a great meeting. Fourth time, remember, be in Rome, Italy next year in September for the International Congress of Shoulder and Elbow Surgery and also physiotherapy. Alex Castagna and Stefano Gomina, they are heading a big team of Italian colleagues, and this is on behalf of the This is on behalf of the International Board. Yes, it's here. Good, thank you. Again, for one more time, International Board is not a society. These guys here represents the 5 continents. And the board was established 30 years ago by Dr. Charles Neer in order to organize one World Congress in a time that there was none international meetings. Nowadays, every city, every hospital has one shoulder meeting. And then these guys here organize this meeting every 3 years. Be in Rome and you will enjoy it. This is my service in Brazil. It was established when I went back from my training with Charles Neer, and we started fellowship about 30 years ago. We have a whole set of fellows, national, international, welcome to visit us. This is our service, and this is my city in the south. Adhesive capsulitis. The consensus is almost none, starting with the title. According to Isaac's current concepts, led by A.G. Toy recently, they had, well, there is no adhesive. There is nothing is adherent inside. So why adhesive capsulitis? We should go back to the days of Kodman, frozen shoulder, and not adhesive capsulitis as Julius Neuweiser have stamped in 1845. So right now, we call both adhesive capsulitis or frozen shoulder. But you see how difficult it is to talk about this subject. Endless list of treatments. Do nothing. That was a title last year in Europe. The neglected treatment of frozen shoulder. Or oral medication. Or suprascapular nerve blocks. Or intra-articular infiltration of corticoid or nowadays hyaluronic acid, or home exercise only, or PT as traditional mentioned, or acupuncture, or hydraulic distension plus manipulation under anesthesia, or arthroscopy, or many others. PRP, stem cells, shockwave. I mean, for a regular guy that comes to this meeting to learn, it's kind of difficult to see this slide. What you want to tell here, Dr. Lech? Well, I'm telling the truth. Everything seems to work well. And then this is the difficult thing, when there is too many ways to go. This is one thing that we face difficulties. And I like this image. It's like a marriage. The orthopedic surgeon or even the physiotherapist get married to someone with frozen shoulder because weeks, months of treatment never ends. And it's kind of hard, this kind of patient too. We all know from the literature the 3 phases. Hyperalgesia and stiffness are painful moments. And then the defrozen time, the pain goes away. But this may take several months. A typical person with frozen shoulder would be a female person after 40 years, sometimes with hormonal disorders, some rare times, but that happens bilateral. The patient comes to your office with several previous treatments. Sometimes she comes with a diagnostic of tendinitis, and not rarely the patient had some infiltrations that don't work. What we must know is that there is restriction in mobility in at least two directions, not only elevation, sometimes the external or internal rotation, night pain, and also during the activities. And the irritative tests are all positive. This is a very typical scenario. So someone with less range of motion, more pain, will sleep badly, and then the problems start. This patient comes in stress, and that's why it's kind of difficult to treat these patients. There are some emotions involved. My approach, since I wrote this article back 30 years ago, oh my God, it's two ways. One is decrease pain initially. You stop everything and try to get rid of pain. And then increase mobility in a later time, but not both together. I don't think this is useful because most colleagues or people that don't know well, they try to do both, and it doesn't work. So since '93, this is my protocol. This paper was badly read for a long time. Nobody paid attention to this paper. But then, with the pandemic, it reached 10 times more the reading. And last year, early this year, it was 700 reads. You know why? Because during the pandemic, adhesive capsulitis rose. So people were looking for how to treat this condition. How do I decrease pain? I like corticoids for the ones that are able to use. I like codeine and paracetamol or dipyron. I like local heat and non-physiotherapy. The articulation has to rest, in my opinion. If the patient comes with this treatment, you can also use lidocaine patches and medication for chronic pain as pregabalin or duloxetine for the ones that need it. So you want to change for pain to no pain. And look at your metabolic disorders, osteopenia sometimes, all of these come together. For the youngsters here in the room, how to do a suprascapular nerve block. I like to do in a weekly basis. Once a week, I put anesthesia and sometimes corticoid exactly there. It's a line crossing the clavicle and the spine of the scapula, and there is a point right in the back of the coracoid process, right there. So you can't miss this nerve. You go inside. You don't need ultrasonography or so far. You can use it, but you always reach the region of the nerve, and when you block it, the sensation of the pain goes away little by little. So that's why you have to be serial, 3-4 blocks. And your direction goes from medial to lateral and from anterior to posterior. And it works out well in my hands. When you have 80% less pain, then you go and try to get range of motion again. Poly exercise at home, hydrotherapy, passive rehabilitation. Not much stretching, not much strengthening, heat before, ice after, and so PT team knows how to do it. I used to give to the patients a program, something like this. It's well known worldwide. So it's exercise that the patient can do at home. Well, what about if I did everything in this protocol and never happens? Well, here we have 2-3 months without improvement, like this patient, 60 years old, 11 months of evolution, several treatments, 4 nerve blocks that I made. And the elevation is only 9, very poor abduction, almost no external rotation, like you will see here. Almost nothing, no elevation, bad abduction, almost none external rotation for almost a year. So this patient had a very poor and limited conditions to pay her treatment. So I went ahead and I did one thing that is nobody does anymore because it's out of fashion. It's not nice to speak on manipulation in a meeting, I know, but I will do it. The patient is under anesthesia, it's just a relax. I strongly support her scapula and go slowly, clock. The capsule is broken, it's distressed. And I do this several times, as you can see here. So I could feel the click when the capsule is ruptured, the inferior capsule. I do it several times. And then, this is real time, I'm sorry, it takes a little while. And then I go for abduction, only until 90. One time I did a little more than 100 and I dislocated the shoulder. That was bad, but it happened. Only 90 degrees. Then, look, adduction. And I'm going to stretch or rupture the fibers in the back of the shoulder because the ones inferior are already ruptured. So, abduction, elevation, abduction, and you see elevation, abduction, and adduction. What about external rotation? Well, this is another video. After you are comfortable with the result, then you do this slowly. Don't be strong, slowly. One time ago, one junior associate of mine had a fracture doing this. So, go slow, you don't have to get the 90 degrees. Well, the good thing about this case, and then right after, gentle fixation in the arm in the zenith position. Zenith is towards the sun. 20 minutes per hour plus physiotherapy, 1 or 2 days in the hospital. Like this. The patient rests pretty well with the arm fixed by the bed in a zenith position. And here we have the patient 4 months after the procedure, well cured, solved. It seems old-fashioned, but this costs nothing. You have to understand this. I'm giving you a very cheap treatment. It's not a sophisticated thing that costs a lot. Well, let's move. Then you can consider arthroscopic release that on behalf of the time, I'm running out of time, I'm going to pass that. I was going to show you here how to do a complete release, but then I will pass that. This is what you see inside. It's all red, all inflamed. And after the procedure, you have this. 4 months later, the problem is solved by arthroscopy too. So arthroscopic release for frozen shoulder works well. A meta-analysis showed that arthroscopy is better than manipulation for abduction and external rotation. But it's similar in the patient's opinion, and it's similar in complication rate. This is something interesting. Can you give me 2? Just a small bit. Right. So, this is what I was gonna show you here. Arthroscopy, it's expensive for us. In some countries it's not expensive, but where I live it is. Manipulation under anesthesia, very cheap. So, and the results look to be the same according to the literature. There are many protocols. This one here says exactly this. Do conservatively during this inflammatory phase and be a little more aggressive when there is scar formation. This other article shows the same. Conservative treatment, 9% get better, manipulation and arthroscopy when necessary. So what I'd like you to keep here is suspect patients with loss of mobility when it comes to consultation. Suspect patients of pain in the shoulder plus diabetes or thyroid conditions. Capsular stiffness is not inflammation. Anti-inflammatory will not do good for them. Consider analgesia first and PT later. And of course, manipulation or arthroscopy if all these have failed. I have to thank from my heart the wonderful reception me and the other international guests had here in this beautiful place. And Professor Adele, you're so kind to receive us as your colleagues, your esteemed friends. And I'd like to save applause for you.